Welcome, students. I'm your lead instructor, Harshal, and I am absolutely thrilled to have you here today. But before we jump into the good stuff, let me give you a quick reminder. If you are enjoying this lesson, please like, share, and subscribe to this channel and share it with friends for this free course on Decode Healthcare with Harshal. Alright, so today, we're diving deep into a masterclass on IPDRG coding. We're going to decode the complex systems that actually drive hospital reimbursement. And I promise you, by the time we're done here, you're going to look at clinical documentation in a completely different light. Let's get started.
Here's a quick look at our syllabus for today. We'll start with revenue cycle basics, move into MSDRG grouper logic, explore the real power behind CC and MCCs, touch on clinical documentation integrity, and then wrap things up with a summary and some next steps.
Section 1. The Revenue Cycle Basics. So to truly understand IPDRG coding, we first have to zoom out and see exactly where it fits into the financial health of a hospital. Take a look at these 7 stages of revenue cycle management. It kicks off with patient access and care delivery, moves over to discharge, and then hits a massive bottleneck at step 4, coding and grouping. This step right here is absolutely crucial. This is where medical coders step in to translate the clinical documentation from the patient's entire hospital stay into ICD-10-CM and PCS codes. Those codes are then fed directly into software that generates the DRG, or diagnosis-related group. Think about it. This single DRG determines the entire payment for that patient's stay under the inpatient prospective payment system. If step 4 is flawed or inaccurate, well, billing, payment, and denial management are going to completely fall apart.
And honestly, that perfectly illustrates why step 4 doesn't just happen in a vacuum. Accurate IPDRG assignment is, by its very nature, a deeply collaborative effort. It all starts on the floor with the clinical teams, the physicians and nurses who are creating the source documentation. Coders can't just guess. They can only assign codes based on what the clinicians actually write down. Then the coding team reviews those notes to assign the codes and select the final IPDRG. Working right alongside them is the Clinical Documentation Improvement, or CDI team. They basically act as the bridge, making sure the provider's notes fully support accurate coding. Together, this trio builds the very foundation of the hospital's Case Mix Index, or CMI, which is a direct reflection of the clinical complexity of the patients they manage.
Section 2. MSDRG grouper logic. Okay, everything starts with the principal diagnosis, or PDX. The strict definition here is the condition established after study to be chiefly responsible for occasioning the admission of a patient to the hospital. I really want you to notice that phrase, after study. A patient might be admitted complaining of severe chest pain, but after testing, the diagnosis is confirmed as an acute inferior wall myocardial infarction. In that scenario, the acute MI is the principal diagnosis. This is so vital to grasp because the PDX completely dictates the major diagnostic category, or MDC. It basically routes the patient into a very specific structural branch of the DRG tree.
But the principal diagnosis isn't the only ingredient in the mix. You can think of the grouper software almost like a highly specific recipe used to classify a case. It looks at the principal diagnosis, sure, but it also factors in any secondary diagnoses representing comorbidities or complications, the principal procedure, secondary procedures, and even patient demographics like age, gender, and discharge status. The grouper digests all of this data to find a single payment group that represents clinical and resource similarity.
Now, what's really fascinating here is how the grouper splits these categories into payment tiers. We call this the MSDRG triplet structure. Let's use heart failure as an example. Depending on the patient's secondary diagnoses, the grouper is going to assign one of 3 possible DRGs. DRG 293 is heart failure without any complications. Move up a tier, and DRG 292 is with a CC, or complication/comorbidity. And at the top, DRG 291 is with an MCC, a major complication or comorbidity. Each step up this ladder signifies a much sicker patient who requires significantly more hospital resources, and because of that, it yields a much higher reimbursement weight.
Section 3. The power of CC/MCCs.
Let's dive into exactly how clinical specificity drastically alters that final payment weight we just talked about. We're going to contrast a vague chart against a highly specific one. Just imagine a patient admitted with vague documentation of shortness of breath and a history of diabetes. That's likely going to result in a code for simple pneumonia without CC/MCC. But now, imagine that same patient's clinical truth was actually much more severe, but the documentation was just poor. If the physician specifically documented that the patient had sepsis and that their diabetes was actually diabetic ketoacidosis, or DKA, well, the entire picture changes instantly.
By changing the principal diagnosis to sepsis, which is a much more resource-intensive condition, and capturing the DKA as a secondary diagnosis, we introduce an MCC into the mix. Notice how the relative weight, or RW, jumps up to 1.9015. It literally more than doubles. This brilliantly illustrates the massive, direct financial impact of accurate, highly specific clinical documentation. The care provided was complex, and with the right wording, the documentation now finally reflects that, allowing the hospital to be fairly reimbursed for their work.
However, there is a very strict rule governing these secondary diagnoses, and you need to know it: the present on admission, or POA indicator. Coders have to append a POA indicator to every single diagnosis. A Y means the condition was present at the time of admission, an N means it was not, U means there's insufficient documentation, and W means it's clinically undetermined. Why does this matter? Well, because Medicare is simply not going to pay you more for a complication that the patient developed while they were under your care.
So, let's look at how that POA actually impacts payment in the real world. If our sepsis patient came in with DKA, that's POA Y. It counts as an MCC. Awesome. But what if they were admitted for sepsis and 2 days later they developed an acute deep vein thrombosis, or DVT? Even though a DVT is normally an MCC, it gets a POA indicator of N because it was not present on admission. Therefore, it's classified as a hospital-acquired condition, or HAC. The grouper logic will completely ignore that DVT for the purposes of increasing the DRG payment, and honestly, the hospital might even face a quality penalty. You only get credit for the severity the patient brought through the front door.
Section 4. Clinical Documentation Integrity.
Because precise words matter so incredibly much to the grouper software, hospitals rely heavily on clinical documentation integrity, or CDI. These specialists review charts concurrently, meaning while the patient is still in the hospital. When they spot a gap, they issue a query to the physician. So what actually triggers a query? Primarily, it's ambiguous diagnoses, like writing history of stroke instead of specifying a history of cerebral infarction due to embolism. Or missing severity, like writing CHF instead of acute on chronic systolic CHF. Or missing cause and effect, where a clinician fails to link a complication to a specific procedure. The ultimate goal of the query is always to obtain an accurate diagnosis that leads to the correct IPDRG.
But listen up, there are very strict rules for how you ask these questions. You absolutely cannot lead the physician. You can't just say, "Hey, Dr. Smith, please document acute blood loss anemia so we can get paid more." That is totally non-compliant. Instead, a compliant query looks more like this. "Dr. Smith, the patient's HGB is 6.2 following surgery. Can you clarify if anemia is acute, chronic, or due to another cause?" See the difference? This presents the clinical indicators, in this case, the low hemoglobin, and asks for the provider's medical judgment without biasing them in any way.
Missing specificity is one of the absolute most common reasons for a query. Coders cannot assume anything. If you write pneumonia, they can't code pneumonia due to Klebsiella, even if the lab results clearly show Klebsiella. The provider has to explicitly write it. If you write fracture of femur but fail to specify right or left, the coder cannot assign a specific DRG. If a patient has osteomyelitis, we need to know the exact site: femur, tibia, sacrum. Without this detail, the chart defaults to an unspecified code, which almost always results in a lower payment tier. Ultimately, what CDI is doing here is known as ethical optimization. We aren't trying to make patients look sicker than they actually are. We're simply ensuring the documentation accurately reflects the true severity of illness and the risk of mortality. By adhering strictly to Medicare rules and clarifying those vague diagnoses, solid CDI practices protect revenue and ensure the hospital is compensated appropriately for the heavy resources they actually utilize to save that life.
Section 5. Summary and next steps. We have covered an incredible amount of ground today, so here is your rapid-fire summary. First, the IPDRG is the engine of the entire revenue cycle. It determines the final payment. Second, the principal diagnosis, the condition after study, is the key that unlocks the major diagnostic category. Third, secondary diagnoses, classified as CCs or MCCs, determine your severity tier and act as a multiplier for your payment. Fourth, present on admission indicators are strict compliance tools that prevent hospitals from profiting off of hospital-acquired complications. And finally, CDI queries must always be compliant, non-leading, and based purely on the clinical evidence already in the chart.
Before we wrap up, I want to leave you with a provocative thought to take back to your wards and offices. Think about this. Does your current clinical documentation truly reflect the severity of illness and risk of mortality of the patients you treat? Because if it doesn't,
Your hospital is leaving survival-critical revenue on the table, and your quality metrics are suffering unnecessarily. Good clinical care absolutely must be matched by excellent clinical documentation.
Thank you so much for joining me today. I really hope this lesson has illuminated the vital importance of the IPDRG system for you. As a final reminder, if you are enjoying this lesson, please like, share, and subscribe to this channel and share it with friends for this free course on Decode Healthcare with Harshal. Keep learning, keep coding accurately, and I will see you in the next explainer.